Thank you very much, Ganaka, for that introduction, and good morning to all of you. First of all, let me thank the Ceylon College of Physicians for giving me a chance to speak to you today about this topic. So I thought I'll speak to you on brucellosis. Are we missing it? And I also bring greetings from my former trainer in the UK, Professor Nick Beeching, who is a brucellosis expert actually. He was very pleased that in the January issue of the Clinical Medicine of the Royal College of Physicians of London, all this tropical medicine CME articles were written by Sri Lankan authors who are all his good friends. And that was, I think, on the initiative of Professor Arusha Disanayake, who is our president of the college this year, who is also the editor of one of the international editors of the journal. So with those greetings, basically let me introduce to you the outline of my talk. I'll first say a few words about the bacterium that causes brucellosis, then about the epidemiology, a bit about the clinical presentations, which I think is what you would be most interested in, and then about the diagnosis, which I think is the single most important message I want to share with you today, number 3 and number 4. And number 5, I'll talk about the treatment just in basic outline because it's something that has to be individualized to each patient. And finally, I'll just ask this interesting question, are we missing it in Sri Lanka? So basically, the bacterium that causes brucellosis belong to the species of Brucella. These are gram-negative bacilli or very small bacilli, so therefore they are sometimes called cocobacilli. There are many species, and in our body, they can live as both intracellular and extracellular parasites. They can in fact actually invade our macrophages, get inside their lysosomes, and live inside the acidic environment of the lysosomes. So they belong to that category of pathogens called stealth pathogens, which like get into the macrophages, into the lysosomes, and travel throughout the body using the macrophage as the vehicle. So that's the important thing about brucellosis, because that kind of stealth pathogen will invariably produce, or will tend to produce, an infection which can relapse very easily. If you talk about the epidemiology, well, in nature, the infection is found in domesticated mammals, such as cattle, sheep, and pigs. So it's very, very, very commonly seen in areas, rural areas, where there's a lot of animal farming. But actually, even outside that, it can be seen in other mammals also, even wild mammals also. It can live also in the environment once it is excreted, especially in cold, damp material, which is especially if it is full of organic matter, and also sunlight kills it. So therefore, if it is cold, damp, and dark, in dark areas or non-sunlit areas, it can stay for weeks or months in that sort of situation, and then infect somebody afterwards, both directly and also through inhalation. So human beings are infected either directly, that will be basically animal handlers and people who work in farms, and also indirectly through inhalation of the aerosolized bacteria from such material, plus also by consuming raw or unpasteurized milk and milk products. So these are the ways that we become infected. The disease in animals is very important epidemiologically because that is the natural reservoir of infection, and we get it from the animals. So that's why it's called a zoonosis. So the veterinary sector is very important for a given country. They are the ones who actually are able to control even human disease, because if they can control the animal disease, the humans are, they escape. On the other hand, if the animal disease can be actually eradicated, as has happened in some countries, the humans will not get the disease. And I'm very happy to say that in Sri Lanka, our vet sector is very active on brucellosis. It appears that we got brucellosis somewhere in the 1970s when we imported Indian cattle, and that's how it came to the country. But our vet sector has been very active in surveillance and vaccination and so on. So like from time to time, they find out that it's very common in the animal sector in certain provinces, and they immediately take action to try to reduce that amount infection in that particular province. So it varies from year to year depending on surveillance and vaccination programs and so on. And the disease in farm animals is very important for us also because it's an important historical feature. You can ask your patients, Do you have access to farm animals? Do you work in farms? In your farms, has an animal died or aborted, and so on? So that's an important, like a epidemiological question we can ask, because that's often found to be the case in areas where it's endemic. And of course, from animal milk, if we consume unpasteurized milk or milk dairy products, we can get it by ingestion through the GI tract. Now, the clinical spectrum in human beings, there are three main presentations, although some textbooks actually say we should not try to divide them into clinical presentations like this. I personally think, at least for the sake of understanding and remembering, it might be easier to think of it as categories. So the three main categories are: you can get an acute typhoid-like illness, or second, you can get a focal infection, that is fever plus a focal infection, like especially the musculoskeletal system or the genitourinary system or the reticuloenteral system. The most important, the most frequent is the musculoskeletal system. And the third presentation would be a chronic fever. And even before the bacterium was discovered, it used to be called undulant fever, which basically means that the chronic fever is an intermittent periodic fever. So the patient has fever for about 2 weeks or so, and then the fever settles down, and they are okay for about a week, and then they get the fever again. So that's called an undulant fever. So that's the typical presentation, but of course it doesn't have to be always. So they are the three main categories of clinical presentations: an acute typhoid-like illness, a fever with focal infection, and a chronic fever, which might be undulant or periodic. So basically, if you think of the acute illness, it's basically a acute or subacute onset, might have lymphadenopathy or organomegaly like liver and spleen enlargement, might mimic glandular fever syndromes. So basically, we have seen these sort of cases a lot in our own practice, and we would think of things like typhoid fever, IMN, HIV, toxoplasmosis, CMV, and various other illnesses. So I think in that situation, brucellosis is also known to be a cause. The second one is fever with focal manifestations. If you take the musculoskeletal system, you might find a monoarthritis or oligoarthritis or even a polyarthritis. It might affect the axial or the peripheral joints. The common joints which are affected are the knee, the hip, the sacroiliac joints, especially unilateral sacroiliac joint involvement, lumbar spine, sternoclavicular joint, which is a fairly special joint for infection, and the shoulder joint. And generally, this joint involvement is not as destructive or suppurative as you would expect in other conditions. For example, in septic arthritis, you will expect a lot of pus formation and, like psoas sepsis and so on as well. But not so much in brucellosis. The destruction is much less. For example, in tuberculosis, it can be very destroying and erosive, but in brucellosis, it's not so much. It's a little bit more chronic and less destructive. The second common system to be involved is the genitourinary system. In the male, they can get orchitis with testicular pain or prostatitis. In the female, anywhere it can be affected from the cervix to the ovarian ovaries. So they can get chronic salpingo-ophiritis, they can get tubo-ovarian abscesses, they can just present with dysmenorrhea and menorrhagia, and they can also get cervicitis. So the whole spectrum is possible. Even in the male, I forgot to mention, they can also get seminal vesiculitis, which is difficult to diagnose without a rectal examination. And if you look at the involvement of the reticuloendothelial system, they can get generalized lymphadenopathy, even visceral lymph nodes like mediastinal lymph nodes and so on, and liver and spleen enlargement. So it can happen in about 20% of the patients who get brucellosis. Other systems are affected very uncommonly, maybe 2% or so, less than 5% anyway. The nervous system, you can have meningitis, encephalitis, meningoencephalitis, cranial nerve lesions, Guillain-Barré syndrome, and so on. In the CVS, we can have endocarditis, including embolic phenomena and mycotic aneurysms, even in the brain. You can get myocarditis. Very rarely there can be lung involvement, nodule formation, abscesses, and so on, but that's pretty uncommon, maybe about 1%. So those systems are very uncommon. The frequent ones are the musculoskeletal, genitourinary, and the reticuloendothelial. So I thought I'd just share some photographs of X-rays from the internet. I don't know whether it's very clear, maybe. You might see this is a plain X-ray of a sacroiliitis. On the left-hand side, you can see that towards the lower part of the joint, you can see the narrowing of the joint margin and the sclerosis and the erosions and the uneven joint margin. But of course, this is not very sensitive. The better test to do would be the MRI scan, which can clearly see the involvement, including bone marrow edema in the surrounding bones. That will be very clear cut. You can see it very easily over there. These are some photographs of spondylitis. You can see several vertebral bodies in the lumbar spine being affected. You can see that they are normally unifocal, but they can be multifocal, and they are not sort of contiguous to the extent that you find it in tuberculosis. They may be non-contiguous involvement. And as I said earlier, they don't cause so much of destruction as you would expect in tuberculosis. Even if you find suppuration or pus formation, it won't be a big collection, and you probably won't find psoriasis abscesses that much, although in this particular one in X-ray B, you can see that there is a psoriasis abscess. This is another one. This is, of course, you can see a bit more contiguously involved, like above and below the disc, and that looks a bit more like tuberculosis. But as you know, in tuberculosis, the involvement is more thoracic than lumbar, and it also gives rise to wedge collapse and also gibbous formation. These are unlikely in brucellosis, or uncommon in brucellosis. So the chronic variety, what was classically called undulent fever, that's when they get very prominent night sweats, even drenching, and anorexia and weight loss. So they are the three main manifestations of brucellosis. Let's talk about the diagnosis. I just want you to try and remember these three aspects. First is, the first important point about diagnosis is to elicit a history of possible exposure to infection. So about 70% of people are animal handlers or people who have been exposed to farms or farm animals, either by handling them, such as abattoir workers or people who work with the animal, or even by just cleaning the things and dealing with the organic matter and therefore getting the inhalation of the aerosolized bacterium. So any exposure to animal farms, animals would be an important point to ask, and that's about 70% of patients. The second important point is to ask about milk consumption, whether you consume unpasteurized milk or dairy products. Now, this doesn't have to be a rural person, can be an urban person who went to the rural areas for a trip or something. It could even be an overseas exposure, in areas where you know that it's endemic, like the Mediterranean region and the Middle East. And you must very carefully ask about, because some unpasteurized milk products are thought to be fashionable, like soft cheeses and so on. So, like when you go to 5-star hotels, you are served these things and they will, enjoy the soft cheese and get brucellosis a few months later. So that's the first point to ask, a possible history of exposure to the infection. The second point to check is whether you have a compatible clinical picture, which I may describe to you. Is it a typhoid-like illness? Is it a focal infection or a chronic fever? Unfortunately, hematology, biochemistry, even histopathology, they are not useful in brucellosis diagnosis because they are either normal or slightly abnormal, doesn't say anything either way. But what is crucial is radiology, because it can show, especially if the joints are involved or the GU tract is involved, you can find that there will be some abnormality. Even in the case of organomegaly and lymphadenopathy, they will be useful. So I think the most important form of investigation for brucellosis, apart from microbiology, would be radiology. So that's the second point. The third point is you have to liaise with the microbiology laboratory, because you have to have laboratory confirmation to be certain that it's brucellosis, and that requires discussion with the microbiologist. So basically there are three tests that they can do. First is bacterial culture. You can take specimens like blood or bone marrow or joint fluid. It requires prolonged incubation and also special media, subculturing into special media. So that's why it's important to talk about the possibility of brucellosis with the microbiologist, because as you know, the microbiology laboratories cannot incubate a blood culture or bone marrow culture forever. They normally incubate for about a week or two because of the high turnover required. But if you suspect brucellosis, they'll be very happy to keep it for even 6 weeks, because they can grow much later. And also they have to do what I call blind subculturing into a special media after every week to try and grow it in those media as well. So that won't happen unless if we tell them, because nobody can suspect brucellosis by looking at the blood specimen. So we have to share with them the information that there's an exposure to animals or unpasteurized milk. We must share with them that the clinical picture is compatible with brucellosis, and then they will do that. So that's very important. Second thing is PCR. That's much more useful than blood culture because it's more sensitive. But again, you must do it as early as possible before starting antibiotics and so on. So again, it's important talk with the laboratory. And the third test is serology. There are various antigen antibody tests which are available, but in Sri Lanka we have the SAT or the standard aggregation test, which can be used to diagnose either with a single high titer or a fourfold rising titer. Now the important point is all these three tests are available in Sri Lanka at the Medical Research Institute. So speak to your hospital microbiologist or to the Department of Bacteriology at the MRI, discuss with them that you are suspecting brucellosis, and then they can make those arrangements. And always consider tuberculosis as well, because that can also mimic brucellosis, although there are subtle differences. I'll just outline treatment. Basically, you need prolonged antibiotic therapies because of the need to prevent relapses. So you need longer courses for more complicated disease, especially with suppuration. Some in vitro effective antibiotic classes actually may not be effective in vivo, for example, beta-lactams and fluoroquinolone, so we don't use them. And the antibiotics which are used against tuberculosis, such as streptomycin or rifampicin, are used here, but they should not be used alone. So I'll just give an example of a regimen, just as an example. We may start off with 3 antibiotics. For the first 2 weeks, we'll probably give an aminoglycoside, such as streptomycin or gentamicin, for 2 weeks, and then continue maybe the other 2 orally, rifampicin and doxycycline, for about 6 weeks. And then it's important to follow up the patient for up to 2 years because they can have a relapse. So it's basically the treatment outline, but that's very variable. That has to be individualized to each patient. Right, my final question is, are we missing it in Sri Lanka? Now, in Sri Lanka, brucellosis is widely prevalent in animals. I told you that it was imported probably from Indian cattle in the 1970s, so it's still there in a big way. And basically, the veterinary surgeons do a very good job throughout the country of maintaining surveillance and doing vaccinations and trying to cull the animals who are infected and try to keep it as low as possible. So nevertheless, it is present. And we did a study a few years ago to look for the serosurveillance of antibody formation to Brucella among healthy people living in those areas. We did it in 4 provinces, and we found that about 7 or 8% of people were actually positive for antibodies, which is a very specific antibody. And the important point is there were clear-cut association statistically with people who are animal handlers or exposed to farm environment. So it looks like our people who are working in those rural areas do actually get asymptomatic infection. That's why they got the antibodies. And Indian studies have also shown that raw milk consumption is a very high possibility risk factor for brucellosis. And also we see it occasionally in returning travelers as well. So my important question is, are we missing it in Sri Lanka? Because first of all, we don't ask the epidemiological question. And secondly, we are not quite aware of the clinical presentations. And thirdly, because we don't speak to the microbiology laboratory. If we keep those 3 things in mind, I think we might be picking up Brucella cases. To be honest, we actually did pick up a case a few months ago in our Prof unit, and it's actually in press now, the case report. So we believe that it is present and we are missing it. So my take-home message for you is basically remember the epidemiological history, animal handlers, farm exposure, unpasteurized dairy product consumption, overseas travel. Remember the comparable clinical pictures, the acute febrile illness, which is like typhoid, the acute fever with focal infection, and the chronic undulent fever. And remember to speak to the microbiologist, because we have to send the right specimen at the right time, and they have to be aware of the fact that we are suspecting it so that they can do the right test for them. Thank you.
Thank you, Panduka. It's an excellent presentation, presenting it in a very simple way. It's open for questions. People who are on virtual can type it in the Q&A box and we'll get the answers to that. We already have 2 questions, Panduka. What was the clinical status of people who had positive antibodies?
They were asymptomatic. I think you are talking about our CMJ paper. They were all healthy people.
Right. So antibody positive does not mean that they either they had the disease or is it
asymptomatic infection.
infection?
Yeah, so I mean, in any infection, we have infection, disease, and complications. So these are people who are exposed and infected, but never had the disease.
Right.
So about 8% had infection.
Thank you. And another question I think you have already answered. Has any screening process done among cattle? I think it's.
Oh yes,
you said
yes,
the
they do
veterinary
it all the
people are
time.
doing it in our country as well.
Yes, they do it all the time.
Drug regime and duration of treatment, again, I think you have.
Yeah, I mean, it's a little complicated. It has to be individualized. So I just, generally speaking, 6 weeks of oral therapy combined would be a very good idea to prevent relapse, something like doxy plus rifampicin. Maybe the first 2 weeks you might also want to combine with a aminoglycoside that will increase the symptomatic improvement very rapidly. So that's basically the structure, but like if there's suppuration, you will have to do more things like surgery, you may have to prolong the infection. If it's CNS infection, it has to be different regimens. So I mean, I don't want to go into details of that. I would probably we'll have to just look at the case and decide what to do. It's very individualized, okay. But the rough picture is that.
Thank you, Panduka. Any questions from the live audience here? One more question. Is there any specific pathognomic features clinically? I don't think that you said.
Probably not, but if I see someone with fever and unilateral sacroiliitis, I would say it's brucellosis until proven otherwise. The only other real DD is tuberculosis, isn't it? But yeah.
Yeah, probably TB may be more common in our experience,
yeah.
But probably we'll be missing because diagnosis is difficult with the brucellosis, probably. Other question comes to my mind is it always, say focal, like musculoskeletal, is it always with fever that we are a suspect? If you don't have a fever, which we don't have a proper diagnosis of, say, sacroiliitis, still it's possible? Or?
Well, I mean, Manson's has a nice table which describes the symptoms. Fever is present in about 95 to 100, over 95% of people. So I would imagine you will expect them to be febrile.
Any questions, Ganaka?
That cause meningitic type of syndrome as well?
Yeah, just maybe 1% or around that level. Meningoencephalitis, the CSF shows high protein, normal or low sugar, lymphocytes. So it's like a chronic meningitis. Can be you might think of TB, fungal, and you might find focal lesions. What sometimes they are called neurobrucellosis. You might find cranial nerve lesions, GBS, and so on. But these are really uncommon, but they can happen.
Thank you, sir.
Another question just come up. Can we differentiate TB from brucellosis on bone involvement itself?
Radiologists are fairly confident because of the tempo of the illness and the degree of destruction. When they combine them together, it looks little bit more benign than tuberculosis in terms of both destruction, deformity, and complications like suppuration. But you have to go for microbiology to confirm it. And the point is probably because it's chronic, by that time blood culture won't be very useful, so you are stuck with the antibody and the PCR. So that's why it's very important to speak to the laboratory to organize that. Even in our case report, we did that. Yeah, I mean, it does have its pointers. Radiologists are very confident when they see these MRIs.
The PCR is from the site of problem, or is it blood?
Any material, blood, we did with the blood, but it was negative. We got it from the antibodies, but you can use blood or any specimens.
Okay. Another question: seroprevalence indication of for treatment?
Sorry?
If there's seropositive without symptom, like asymptomatic infection, do we need to treat?
That's a very interesting question. There is something called asymptomatic brucellosis. I would probably not rush in to treat really. I mean, even in our sero surveillance study, about 80% were actually antibody positive. Of course, we did not treat any of them. They were completely asymptomatic. I don't think that we need to treat them, but provided if they are symptomatic, then we have to evaluate clinically to decide whether to treat or not. But if they are completely asymptomatic and picked up accidentally, like in a research project, I don't think we need to treat them.
Okay, Panduka, thank you very much for your time and very pleasant presentation. Excellent presentation. Thank you very much on behalf of the college.